Hi, everyone, and welcome to episode 141 of the Veterinary Behavior Chat podcast. So today's episode is a little bit inspired by my visit to BVA Live in the middle of the month, so middle of June. I was at BVA Live exhibiting with Trinity Veterinary Behavior, and I had the honor of also presenting a lecture there on kind of an introduction to psychopharmacology. And one of the questions that came up, or one of the topics I think that, there were many questions on, was whether the combination that is really frequently sort of recommended, which is gabapentin and trazodone as a PRN, so an event kind of medication combination, most commonly, I guess, prescribed for veterinary visits in dogs, whether that is always the best option. And, there were a lot of vets in the audience that said they had seen adverse sort of effects from using that combination. So I thought I would do a little bit of a deep dive into that. And it's actually funny because one of the things I said during the conference was I have a love-hate relationship, especially with trazodone. But yeah, I have a love-hate relationship with that combination. And I think that got even more questions being asked sort of after I said that. And I guess I want to start off by saying that, obviously having anything at all that is an anxiolytic combination is brilliant. And the fact that, more and more vets are embracing event medications, PVPs, medications to help their patients out during vet visits, that's hugely commendable. But I just want to challenge a little bit the idea that gabapentin and trazodone is kind of a one size fits all, and that it's a bit of a sort of a blanket combination that's used very regularly. And I think, it's something I think that has gained familiarity, so vets potentially feel more comfortable prescribing this combination. I think they know what to expect in the majority of cases. We have had, a number of papers in dogs and cats on gabapentin and trazodone specifically for pre-vet visits. So there are a lot of, I would say, pros. But what I want to really sort of warn against is this combination, or even the one or the other medication on its own, just kind of being handed out almost like Smarties to everyone without considering what they actually do and what might be the patients that might not respond so well to them. The other big distinction I just want to make here quickly is cats versus dogs. So I think for cats, traditionally gabapentin and pregabalin, so we have a licensed a formulation of pregabalin, that's Boncat, which is licensed for veterinary visits in cats. So there is that piece, especially if you're working in a country where that prescription cascade piece is really important, such as the UK. But I think in cats, traditionally, gabapentin and pregabalin have been very reliable, and they've been almost kind of game-changing, I would say, in sort of feline medicine, and especially in the use in cats as a pre-visit medication. Again, that's not to say that that's the only option for all cats. I have seen some cats where gabapentin alone hasn't been enough, and we have used trazodone or a combination of gabapentin and trazodone. And really excitingly, Dr. Asher Feldman presented a study at the Veterinary Behavior Symposium in Seattle this year, where they looked at the use of Cilio, so oral transmucosal dexmedetomidine gel, in the use of healthy cats, and they looked at its efficacy, ease of application, anxiolytic effects, cardiovascular effects, hemodynamic effects, all that sort of thing. And that, so that is definitely being looked into further and further, that we have other options for cats as well. I also know for cats, benzodiazepines can be used or are frequently used. I know that clonidine tablets are used for cats by some of my US colleagues. So I'm not saying that gabapentin and pregabalin are the only options for cats, but I do feel that they're very reliable options for cats. And I haven't perhaps had the same experience for our canine patients, especially where it comes to pre-veterinary visits. And I've heard very frequently, especially in my behavior patients, that gabapentin and trazodone maybe caused even more anxiety or stress, or, caused irritability or activation, or just didn't have the desired effect, which was anxiolysis to help the pets feel calmer and make them more easily handleable and examinable, and so on. And I just wanted to delve a little bit into why that might be and what other options we have for dogs specifically. So let's start off with gabapentin. I think one thing that we have to remember is that at an anxiolytic dose, which to me usually starts at around 20 milligrams per kilogram, at an anxiolytic dose, we may, in some individuals, have quite significant sedating effects. And that can, for some individuals, put them into quite a vulnerable spot. So I'm thinking specifically about dogs who maybe have chronic pain issues, who have musculoskeletal issues, that if they do become ataxic or sedated, that makes them feel even more sort of vulnerable, and that in itself might increase anxiety. So I think whenever we are using gabapentin, whether it's as an event medication or even if it's on a daily basis, we have to be really mindful that we don't create a state where the patient feels more vulnerable than before, because I think that is not what we want to achieve, but that can also affect emotional state, which is anxiety. So, I think, yes, absolutely, gabapentin can be brilliant for some dogs, and we do still use it a lot, but just be mindful of those individuals. And this kind of goes back to what I said earlier about not using a blanket, one size fits all combination of medications for everyone. Now, in dogs, gabapentin as a PVP has a really wide dose range, right? So anywhere between that 20 to up to 60 milligrams per kilogram is what's in the research. So there's a wide dose range, and depending on how the individual responds, we might want to adjust that dose range for that individual. So that's another thing to think about. Trazodone is a really interesting one in dogs because trazodone does have some activity at the 5-HT2C receptor, which is that receptor that also fluoxetine can target, that can cause increased activation. And that might mean more irritability, maybe more anxiety, more movement instead of less movement. So it might actually achieve the opposite of what we're trying to achieve. And I know so many patients that have shown kind of almost like a paradoxical effect. So the opposite of what we're trying to achieve from trazodone. The other thing we need to think about with trazodone is indeed the dose. So at lower doses, so somewhere between 2 and 5 milligrams per kilogram, we potentially have a more hypnotic effect, whereas at higher doses, we maybe have a more anxiolytic effect. So that's anywhere between 5 and 12 milligrams per kilogram. And it depends a little bit on what you're trying to achieve as to which dose range you choose. And also, I think it depends a little bit what combination of medications you're thinking of prescribing in terms of synergistic effects. So would it be better giving a slightly lower dose of each medication and therefore producing a synergistic effect rather than having high doses of individual medications? So I recently saw a patient, in fact, just yesterday, where we had a really high dose of gabapentin, I think 40 milligrams per kilogram, plus 10 milligrams per kilogram of trazodone. And that particular patient really struggled with that combination. And this is a dog who potentially is painful and does have some musculoskeletal challenges. So that was, for me, one of those examples where the dog was quite sedated, but not really, it hadn't really reduced the dog's anxiety levels. So, and the dog just kind of felt weird. And I think that in itself then caused more anxiety. And the caregivers also found it a not very nice experience to see their dog like that. So, yeah, I think, that's definitely something that we need to think about. And like I say, with trazodone, also that sort of potential activating effect can be really pronounced. And, might not be helpful in the veterinary setting and might actually cause the opposite of what it is that we're trying to achieve. So what do we do? Well, I think that there are a couple of things. So the first thing that I would obviously always recommend is, if we can, to do some trial doses at home. to do a trial dose of the suggested combination of medications to see what effect they have without the urgency of an event. So where the caregiver can just observe the dog or cat at home over a longer period of time to see what kind of effect the medication has, how long it takes to start working, when is its sort of peak of effect, when is its maximum effect, and then when does it start to wear off again. And I think, that, yes, we potentially have obviously a slightly different context without the stressor of a car journey and the stressor of actually arriving at and entering the veterinary clinic, but it would give us a bit of an indication, certainly, as to whether, for example, trazodone has a more activating effect, or whether maybe gabapentin has a very sedating effect, whether it causes ataxia at that particular dose. So trial doses are really important. The second thing I would say is to not be scared of using other medications in this pre-visit combination. And I'm thinking specifically about the alpha-2 agonists here. And I feel that alpha-2 agonists potentially are somewhat underused or underthought about when it comes to PVPs, pre-visit pharmaceuticals. And I think that, again, is a little bit because this whole Gaba Traz thing has become so popular and ingrained that sometimes we forget to think outside the box and think about what other medications we have at our disposal. So one combination I, for example, really like using is gabapentin, trazodone, and clonidine, all at lower doses, because we have a synergistic effect, and we've got 3 different neurotransmitter systems that are being targeted. So we have trazodone that targets the serotonergic system, we have gabapentin that targets the GABAergic system, and then we have clonidine, which targets the noradrenergic system, so noradrenaline. So we're quite safe. We're targeting 3 different neurotransmitter systems, so we're not risking, let's say, 2 or 3 serotonergic agents on top of each other that might cause serotonin syndrome or something like that. So it is quite a safe way, or quite a good way of getting that multimodal synergistic approach. And think about it a little bit like a multimodal anesthesia plan, right? You're using different medications to achieve slightly different things, in the hope that their synergistic effect will be greater than each individual medication on its own. And then, of course, we have other alpha-2 agonists. So Cilio gel, which is dexmedetomidine or a transmucosal gel, which isn't licensed for vet visits, but is licensed for short-term use for noise fears. Then we have detomidine gel, which is one that I really like. So many of you who know me know that I will often talk about detomidine or a transmucosal gel. So that would be your dormicidin, which is actually an equine product, but that has had some studies and abstracts on use in dogs. So that's something that I really like using. To be fair, I think detomidine gel I would often use as a solo agent, so without the trazodone and the gabapentin, but you could combine them if necessary. And the detomidine gel oftentimes precedes then an intramuscular injection of medetomidine or dexmedetomidine plus an opioid to get to achieve intramuscular sedation and better control over that patient. So that would be another alpha-2 agonist. And then we have Tessie as well, so tasipimidine, which is a new product. Now, again, doesn't have a license for pre-veterinary visits. It has a license for separation anxiety and noise fears, but that could be something that we could consider. So we've got quite a lot of different options. So I think, it's no longer enough to be thinking just about Gabatraz, that kind of, common sort of commonly used combination. Of course, we can also think about benzodiazepines for our dogs. I always would say they'd be lower on my list. And again, I might not combine them. I might. We definitely would need a trial dose for a benzodiazepine, I would say, because we do have more risk of potential side effects like that paradoxical hyperexcitement or disinhibition of behaviors. So, I think, again, there are lots of options. dare I say it, as a combination, maybe even acepromazine could be helpful in some instances, although I'm not a huge fan of acepromazine, but I do know that many of my US colleagues will put that in as long as there is an anxiolytic medication included in the combination. But yeah, I think that the kind of let's just give Gaba-Traz to everyone approach is probably no longer fit for purpose. And again, that's not to say that gabapentin and trazodone aren't really useful medications, and they've certainly opened the door to us thinking about the use of pre-visit medications. But I do feel that there are that there are other options out there, especially if we think that an individual is not necessarily responding well to that combination, or where that combination hasn't had the desired effect, let's say. So just something to think about, and just something to kind of, I guess, take forwards and sort of think about, what that means for your patients and what sort of other combinations you could be utilizing. And again, always that reminder to be mindful of the neurotransmitter systems that the medication targets, so that you're aware. Sometimes also, type of administration can be a challenge. Not all dogs are easy to administer, or a transmucosal gel to, which is Cilio and which is detomidine, so dormocidin gel. Some dogs might do better with an oral liquid, which would be, in favor of Tessie, for example. Some dogs do great with tablets. So there you could think about gabapentin, trazodone, and maybe a clonidine combination. So lots of things always to consider, but I just want you to start thinking outside the box, and not just grab Gaba-Traz. Look at the patient in front of you. Think about their other presenting signs. Think about comorbid presentations such as musculoskeletal pain. Do trial doses, and just start, thinking outside the box, and maybe getting a little bit braver with some of the PVP combinations or options that are out there for you. Okay. I hope that makes sense. I hope that that's useful. I hope that has addressed for many of you a question that I think, we do think a little bit about. And yeah, I hope you've enjoyed this episode. A lot of these things are in my professional guides ebook. So I have a paper or a handout or a professional guide on clonidine in there. I'm just about to write one on Gaba-Traz, so that's something that you can pass on to colleagues, or that you can even pass on to caregivers to start sort of thinking about those things. So the professional guides ebook has a lot of information, a lot of this information in a handout type form. So that's something that you might be interested in. I'll pop the link to that in the show notes. And the other thing, obviously, if you want to understand more about these medications, is my psychoactive course, where I go into much, much more detail about the individual medications, and also how they can be combined and how they can be practically used. So I will also put the link to psychoactive in the show notes. So they might be two further resources that, if you found this topic interesting and useful, that you might want to go to next. All right. Thank you so much for tuning in, and I'm going to see you all next week for episode 142. Bye for now.